Hi students, welcome to your image analysis class. Your first chapter is on the image analysis guidelines. So we're going to talk about different ways that we acquire the image and some of the reasons why the image does not look good. We're going to talk about marker placement and collimation. So let's get to it. We're going to look at here what is image analysis. So the reason why we do it, we need to look at the images and make sure that they are of quality so the radiologist is able to read the image and find a diagnosis for the patient. So evaluate projections for acceptability, determine how to improve positioning and technical skills before repeating the projection. So I'm going to talk to you about how to figure out how far it's off and what to do to correct that without just going in and guessing. So this will help with your repeat analysis. It'll help with radiation exposure to the patient also. And it's really good for you to continually improve. So the goal is for you to be able to look at an image and say, okay, this is what's wrong with it and this is how I'm going to fix it without having to guess. So, as you can see here on this chest x-ray, they've labeled the vertebral column and the left sternoclavicular end. And if you look here, only 2 to 3 degrees of rotation will affect the appearance of the lungs, causing differences in brightness values along the lateral borders of the chest x-ray. So if you just angled the patient or the patient was angled just a little bit, 2 to 3 degrees can really throw off an image. The one thing that I see on this chest x-ray that I absolutely am not okay with is what? The marker. The marker is in the bony anatomy. If it's in the soft tissues of the upper portion here, if it's in the soft tissues here, I'm okay with it, but if you can get it out of any anatomy, that is best. So as you guys will be in clinic with me, you'll learn that I don't want any markers in the bony anatomy. Sometimes it's really hard, like on a lateral spine or a pelvis, to avoid the bony anatomy, but if you can, you should. Okay, so normal heart shadow on projections will occupy less than 50% of the transverse dimension of the thorax. So one way to measure it is you take the diameter of the heart here. So you'll see radiologists take their thumb and their pinky, kind of like a Hawaiian, hang loose kind of sign. So they'll measure from here to here, and then they'll take it and they'll hold it to half of the diameter here. So if you measure here and then hold it up against here, that's how they determine if there's cardiomegaly. So in any kind of heart failure. So just give you guys a heads up, that's how they measure. So it needs to be at least half, less than half of one side. Okay. So on a wrist, looking here, you can see we have 3 different projections. Looks like 3 different patients. You can tell by the soft tissue here. You can see the R is within the soft tissues. This wrist is a lot bigger than this wrist here, but we're going to talk about the angulation of your lateral. So normally we just have you guys take a look at the ulna and the radius. Are they superimposed? So here, the first lateral wrist projection was attained with the patient's thumb depressed until the first metacarpal was aligned with the second metacarpal. The other lateral wrist projections were obtained with the first metacarpal elevated. So you can see here the trapezium, and you can see the difference between the wrists on which one is going to show us the anatomy the best, okay? So looking here at a PA wrist, the carpal metacarpal joints and the distal carpal bones are well visualized on the first PA wrist, but are not seen on the other 2 projections. So the first PA wrist projection was obtained with the MC aligned at a 10 to 15 degree angle with the image receptor. The second PA wrist was taken with the MCs aligned at the angle greater than 15 degrees, so here, and the third projection was taken with the MCs aligned at an angle with less than 10 degrees. So as you can see here, the differences between them is pretty substantial. Okay, so some of the terminology that you're going to have to know is the path of the X-ray beam, the patient's position, the precise location of the atomic structures, positions of one atomic structure in relation to another, the way a structure will change position as a patient moves in a predetermined direction. So with these, when we talk about the path of the X-ray beam, we're talking about which way you're angling. So when we talk about the patient position, that is the anatomical part that we're looking at. And then the precise location of the anatomical structure, we want it aligned with the beam. So the part that we're actually looking at. If you're off-centered with that divergent ray, it's going to close joint spaces. So we're going to talk about make sure you're aligned properly. So that's the precise location of the anatomical structure. And position of one anatomical structure in relation to another anatomical structure. So if we're saying that the medial and the lateral condyles need to be aligned, so we need to specify what the two are and what the relationship is, how far off they are, so that we can correct it. All right, so, and if we're going to rotate the knee medially, we need to talk about how that's going to change what the angle is going to be. Okay, so looking here, an optimal image of each projection demonstrates all of the most desired features, which include, so what we need to have on every film. So the demographics of the patient, so the patient, facility name, the time, the date, the marker. The marker has to be on the film, so it needs to be out of the VOI, which is the volume of interest. So if we're doing a chest x-ray, you can't have a marker in the lung. It's just not okay. If you're doing a wrist, it can't be in the wrist. So you got to make sure, if we're looking at the wrist and we're looking at soft tissue, you can't have the marker in the soft tissue of the wrist. Make sure that the marker is out of the anatomy in which we're interested in. They're calling that the VOI. Desired anatomical structures in accurate alignment with each other. And we're looking for maximum geometric integrity, and we're going to talk a little bit about that. We talked about the distortion, so that's what they're implying here. So size and shape distortion. Appropriate radiation protection, so we need to shield the patients, and we need to shield them in a way that's going to protect them the most. So the best possible contrast resolution with minimal dose. So that's basically choosing the correct cassette size, either your CR plate, and choosing the highest resolution, and to remove all artifacts that are that could potentially cause a misdiagnosis or a repeat. So when we talk about displaying of the images, that has to do with what you're choosing. So it's the patient orientation and how it's going to be hung. Okay, so what you want to do is align along the long axis of the extremities with the longitudinal or transverse axis of the IR. So looking here, you want to be centered on your cassette. So there's little notches. So you're going to want to look for the 4 notches on your plates, or on your DR. There should be a big X right in the middle. So you're going to want to line up so that the anatomical part is in the dead center. Okay. So the one thing I see about this particular wrist that they're shooting is that the marker is on the lateral side, which is great, but their collimation is huge. So you need to bring the collimation in nice and tight. So I usually take it just outside of the widest soft tissue margin. So we're going to learn further exactly where you're supposed to have that collimated filled. So in looking at this foot, so it came up and onto your workstation monitor upside down. So you had your CR plate in there upside down, which is not a problem. But if you flipped it, it's going to flip it so it's hung like a left foot. So you need to take it and flip it right to left. So you flipped it top to bottom. Now you're going to take it and go right to left. This is a good foot image, but the marker is upside down. So it's correct as far as the way the plate was orientated, but the plate was upside down. So you need to make sure you take your marker and you put it in there. A good spot for your marker is actually right here, right along the toes. All right. Looking here, we're talking about the contrast masking. So the contrast masking is what you guys call cropping. It's called many different things. In our program, you are not allowed to mask, contrast mask, crop, whatever you call it. So in this image here, you can see that they have the humerus within the KUB. So what they did is they went ahead and they applied, you can see the black line right here, the masking on the image to take out the humerus. So, in the elbow. That is absolutely not acceptable. I left this in here because really, when you apply a contrast mask, it helps with the contrast resolution in the selected area. So this will be one of your quiz questions. It does. It does help with the contrast resolution in an area that doesn't have it. So it adds a black background over outside of the VOI, which is great. But if there is anatomy within the image, you cannot cover up the anatomy. So the technologist should only mask to the exposed area, matching the collimated borders. So you are never, never, never to apply this masking over anatomy. So when you are applying the contrast mask, you should prove that you are not in the exposed field by leaving a thin white line around the image. So this masking is usually programmed to come up on a lot of your images. You can remove it and reapply it and draw it in so that you can see that you did not clip any anatomy. So if there is a bony lesion right here and you put the contrast mask over it, the doctor would miss the lesion. So you can miss a cancer. You need to collimate and not mask, okay? So if you left the humeruses in the image, guess what? The radiologist is going to be reading humeruses, okay? So make sure you get those out. And also, they clipped off the marker and the upright by using the contrast mask. So you need to make sure that if you're going to do any kind of masking and your marker is going to be cut off, you need to make sure that you get that on there, okay? So a lot of times you can draw around, so if the masking comes down, you can take it and have it end right there so that it leaves your markers on, because your markers are a legal part of your film that need to be on there. So you're setting yourself up for liability when you're using the masking and you're covering up any kind of anatomy. So it's legal issues that come along with that. So just don't do it. All right, so your display stations. The resolution refers to the maximum number of pixels that a screen can demonstrate. We've talked about this. The display monitor must be able to display the same number of pixels as the digital imaging system that acquired the image that the image can display. So typically the technologist workstation, as we've talked about, has really low resolution compared to the radiologist monitors. So a lot of the times you guys will hit the little magnifying glass to look to see if there's any noise on your images. So when you have an image that comes up, so once a projection is correctly displayed, it is evaluated for positioning and technical accuracy. So what you want to do is the evaluation should follow a systemic approach. So radiologists have the same systemic approach when they're reading, or a very set systemic approach. So you should do this to reduce the chance of missing important details and provide a structured pattern to use in a stressful situation, so that you're in a routine and you're checking over and over and over the images. So within your book, they talk about the best way to do that. So there's in box 1.1 is actually shows you the image display guidelines, which are really good on how an image should be hung. And then they talk about how contrast masking is bad, and then your image analysis form. So I didn't include it in here on your image analysis because, as you can see, it's 2 pages long. So these are all the things when Jill and I come out and talk to you. These are the things that we're going to be asking you, what you find on page 8 and 9 in chapter 1 of your book is, you know, we're going to look, is there grid lines? Is there any artifacts? Is the VOI centered? Those are the things that we're looking for. So make sure you read this and you're familiar with it, because I'm probably going to be asking you most of these questions. And if you are already in the habit of doing this, this is going to make your life a lot easier. Okay, so here it is, very long. So I'm not going to read it to you. You can read it on your own. It's stuff that you're already familiar with. Okay, so we talked about this already. It's already in here that you need to have, the name, date of birth, identification number, facility number, the examination time and date. That's one thing that wasn't on the last one. Also, your CR cassettes have a barcode system typically, and you need to make sure that that barcode matches, the cassette matches the patient's demographics. On your direct image capture in your DR system, you need to make sure that the correct patient is pulled up before you expose the image. That's the most important thing. So when you're looking here on a CR or DR system, on the tube head there is actually measurements, and it's going to tell you exactly where to put your marker. So this is kind of interesting in the sense that it's going to show you from the transverse line and the longitudinal line, if you're collimated to a certain amount, where your marker placement can be, what your field size is going to be for your marker placement. We're going to talk about that. So you're going to use that collimator guide for your marker placement. Now, this is a finger. When you're shooting a finger, it's really hard to get your marker in there. What you're going to want to do is sneak it in just like they did here. So you're going to take your marker, you're just going to kind of get it into the exposed field. So you can see that this is an R. I probably sneak it in a little bit more to get the more of the R on there. Then you can annotate a marker on. So you can see you've got a marker on there for legal reasons. You can see it's not an L. And then you can annotate a marker on. So that is fine. So just sneak it in wherever you can. I do this on odontoids, fingers, toes, whatever I can. I sneak in and try to fog on whenever I can. All right. Your post-processed annotated marker is not legal, just so you know. Okay, so here on this lumbar spine, they got the marker in, they collimated nicely, which is good. So the marker is on the anatomically correct side. I don't like the marker where it's at. I usually put it at the top of the light field, and I put it on the cassette. If it's a DR system, a direct imaging system, I'll slide it under the patient. You are not supposed to put a marker on the patient. One, it magnifies it, distorts it. You should really have the marker on the table or on the imaging plate. So you can see here, I would put the marker right here and my initials. So the marker is on the anatomically correct side. This is great collimation. We're just outside of the SI joints, and it's out of the bony anatomy. A lot of people put the marker down here in the bony anatomy, but you may cover up something, so get it into the soft tissues. So the marker placement here is terrible. So this is an oblique. Guaranteed on the oblique, you're going to put it into the wing. So what you want to do is put it up into the soft tissues. Okay, so put the marker up here. I'm glad they had a marker on, but the marker needs to be up into the soft tissues. And you're more inclined to miss bony anatomy. Unless you're off-centered, you're more inclined to miss bony anatomy. I don't want to see your marker in the SI joint. Okay, when you're doing a decubed chest, you should use a marker with BBs or have an upright arrow so that they know that this is the side up. This is the correct way to hang a decubitous chest. Some people do hang them so they're hung just like a normal chest. I'm not going to say that's wrong, but it's just different. Each side is a little bit different. You're going to want to put your marker here and then annotate or have an arrow or have BBs to prove that this is the side up. If you have your marker going this way, that's fine, because your BBs are going to show, they're going to level out so that they can see that that is the side up or down. Okay, so when you're shooting a hip, the best place, what you can do is you're going to fill in between. So from the greater trochanter to your ASIS, you're going to look in that groove. You can see there's a huge opening right here. This here, it's confusing. Is this a right marker or left marker? Did they mean to shoot the right hip, the left hip? It needs to be on the lateral side. So your marker needs to be on the lateral side. You can even see here you have some light field. You can sneak your marker in right there. So in this cove is the safe place to put your marker. So slide it in right there, the fleshy part. Okay, so here on a shoulder, this is perfect marker placement. I even like the angle, so you can sneak it in a little bit more to get your collimation. I see that they did clip the bottom of the scapula. Typically, we don't clip the bottom of the scapula, or at least have techniques so that we can see the tip. And have the marker in nice and close so you don't have all this exposed area up top. So when you're shooting bilateral hands, you're always going to use a right and a left marker. So anytime you're shooting bilateral anything, you're going to have a right and a left marker. If you're shooting a finger and you're shooting 3-on-1 image receptor, which normally we don't do because of the CR system and the DR systems don't know quite what to do with, well, you can do it on DR, but on your CR systems, they don't know exactly how to process it. The algorithms are going to be screwed up. So your histograms. So you're going to want to do 1 per plate, but if you shoot 2 per plate because they need a comparison, just like this person has really bad arthritic changes and they want to compare it to the other side, you're always going to have a right and a left marker on. When I go see you in clinic and I pull up bilateral hands or ball catcher hands where they have the palms up, you guys only have 1 marker on. That's unacceptable. You need to have both markers on at all times. Okay. So anatomical structure requirements and placement. So as a general guideline, when positioning the VOI on the IR, the long axis part is aligned with the long axis of the IR and orientated for best display and tightest collimation. Tightest collimation is key. So the actual area of the IR that is needed to be included is the required anatomy is defined by the accurate CR centering and good collimation practices. Due to that divergent beam, you need to make sure that you are centered to the VOI. All right, so with DR, the VOI may be placed anywhere on the IR without reducing spatial resolution or causing a histogram error, which is nice. So long bones projection of the humerus of the lower leg may be placed diagonally on the IR. This is not advisable when you're using the CR system because the histogram, it's going to screw up the histogram. It's supposed to be straight when you're using CR. So it's going to have a hard time and give you a false error. You can still do it, and when I come out and I look at your images and your EI or your S number is all over the board, it's because it couldn't read diagonally on the cassette. So this is what we're talking about here. As you can see, if you're trying to get a wrist here and an elbow, you're going to see that you're not going to be able to see the joint space as well because of the divergent beam. You're going to be able to see the main shaft of the ulnar radius, but the actual joint spaces are going to be off. So here, this is an actual film cassette, which is kind of funny. We did this all the time, but with CR and DR, this doesn't work as well. So especially with CR, you may have to shoot 2 separate ones and do them from the longitudinal side, and just do 2. And you're going to annotate that one of 2 and 2 of 2, so that the radiologist knows that there's 2 of them. Okay, so this is what I was talking about. So there is an area here on the collimator box, and this is very confusing, and have your site explain it to you because each one is totally different, which makes life even more fun. So you can look on here and it's going to actually give you numbers that are going to help you. So as a general guideline, each projection should demonstrate a small collimated border around the entire VOI. The only time that this rule does not apply is when the entire IR must be prevalent, must be used to prevent clipping of the needed anatomy, as with the chest and abdominal projections. So you use this collimator guide. It helps you be more confident that the coverage will be sufficient when you are imaging larger patients where your light field is very small. So it'll give you the dimensions and you'll be able to tell what size your light field is going to be so that you're confident. We would use these when the light would burn out, and we'd be able to shoot our images with confidence without a light. So if your light bulb ever burns out, you can use this guide and you'll be confident in knowing that you are not going to clip your anatomy. So the biggest thing is with your divergent beam, the greater the OID, the smaller the light field on the patient. So as you image really large patients, especially like if you're doing a sacrum, your light field may be like 2 inches by 2 inches, which completely freaks you out. It freaks me out. So you need to be confident by using this guide. It's going to ensure that you are covering the proper area because of that divergent beam. Okay, so that's what that's all about, the collimator guide. So this here, I love this image. It's really good for your collimated field. They're a little angled. I don't like how they're angled here. They should be, you know, the humerus should be here and the wrist here. So it's off angled a little bit, but they hung it backwards. It needs to be flipped right to left. Stuff like this bothers me, makes me crazy. It just shows that you're not real confident in what you're doing. So when we're looking at the collimator box, you can turn the head of the collimator box to be with the anatomy. I'm sure you guys do that when you're doing a tip fib. You're going to angle it so that it is lined up with the anatomical part, which is good. But it will screw up your histogram. Your grid, you're going to be fine with your grid, but your histogram, it's not going to be able to recognize the borders real well. So it's best not to do this, especially like on a chest. So you're going to want to just collimate in as tight as possible. So this is great collimation. The marker placement is phenomenal. I love it. You can also put it up here. I don't mind it in the soft tissues. If you just have it in the exposed area, it's probably going to burn out. So I'll sneak it into the soft tissues right here of the back muscles. All right, so over collimation. I see this as you guys get better. You want to show off your collimation skills, which is phenomenal. I love it, but you're going to want to look at your shadows. So make sure that your shadows are within the light field. So a lot of times you guys will get right up to the fingertips, which is great, but then with the divergent beam, you're clipping off the tip of the finger and you have to go back and repeat the image, which is not good. So here is a right lateral hand. I would stick my marker right here if I'm looking for a marker placement. I do not like it on the medial side. If you're at UCSD, yes, you're going to put it over here or down here. There's a natural spot. I don't want to see you opening up your collimator field to get your marker on. So there's places to put it. So if you're at UCSD, you can put it right here. So there's room, and there's also a natural spot right here. If you guys are anywhere but UCSD, because they hang their hands anatomical, so which is backwards from everyone else, you can slide your marker in right there, or you can put it down here and just collimate in nice and snug. So anatomical relationships, so positioning routines and understanding the reasons for the procedures, correlating the anatomical relationships and positioning procedures, identify anatomical structures. We're looking at off-centering, angling of the CR, magnification, elongation, foreshortening, distinguishing between structures of similar shape and size, and determining the degree of patient obliquity. That's where it gets a little tricky. And determining the degree of extremity flexion and extension, and determining joint spaces and fracture lines. So that's what we're going to jump into now. So you can see we're doing a knee. You can see we're off by a little bit. You want to actually have AB going through the joint space, so to open that up. So you have a little bit of a divergent beam, which might close off your joint space. We're looking here. If you're angling, this is just a chest. Normally we don't angle on a chest, but this is just for example. So you can see here, this plane, everything is lined up. But with an angle, it's actually going to throw everything. So this one is the furthest one. So this is your SOD. So here you've got this one that's the furthest away. hitting your IR, where this one is the closest to the source, so it's going to be the most magnified. So this one's the least magnified, most magnified. So you can see how an angle will throw your anatomy off each other. So all these would be superimposed on each other. So it throws them off and will magnify the part closest to your source. Okay, so here's angling. So this is, the first one is perpendicular. This one is angled cephalic, and you can see how it's opened up your obturator there and elongated. And here, this one is angled caudally, and you can see how it's superimposed the superior and inferior pubic ramus on top of each other. So this gives you an idea what angling does. So if you have a structure that looks like it could be abnormal, you may want to throw an angle on it to throw it off, because it could just be superimposition of tissues. All right, so this talks about magnification when we talk about our SOD or our OID. So if we have a larger OID, we're going to have a more magnified image than the one that's further away. And that goes for a chest. So when we're looking at a left lateral chest, which is hung right lateral, very confusing. Very few centers actually hang it in a true left lateral. The right lung is going to be larger than the left lung, and it actually looks like it's wider than the ribs. So not true, it's just magnified, okay? So this is where the central ray is centered to your VOI. This is where it's off-centered, so you can see that we're going to have, and we talked about this in your last 121 class, you can see how it's going to be distorted on this end. And angling, you can see how it's really going to be distorted and magnified compared to this side. And here, how the IR is off-centered, so we're going to have some distortion and magnification. And the object here, we're going to have superimposition, so foreshortening and elongation within the actual image. So having the anatomical part with your CR aligned is really important, because it's going to open up your joint spaces, as you can see here. You can also slide your marker across the top, that's fine. Here, as you can see, the finger is not straight and the joint spaces are closed. So really important to get that VOI centered and straight so that you can open up joint spaces. So when you're repeating, you need to understand what, why, and how you're going to fix your image. So you're going to identify the two structures that are mispositioned. You're going to determine the number of inches or centimeters that the two are mispositioned or off, we'll say. You're going to determine if the two structures will move toward or away from each other when the main structure is adjusted. So if you're going to rotate the knee more medially, what is that going to do to the medial condyle and the lateral condyle? Are they going to move towards, away? What's going to happen? So beginning the repositioning process from the first position, and then move the patient as needed for proper positioning. So if the structures move in opposite directions from each other, adjust the patient half the distance that the structures are off. So if only one structure moves, adjust the patient so that the structure that moves is adjusted the full amount. So if both are moving, then it's going to move twice as fast, okay? If one's moving, you're going to move the full amount, and we're going to talk about that here coming up. So, let's see. You're going to determine the direction in which the structure situated is furthest from the IR must be moved to accurately respect to the other structure. So if you look at 151 in your book, you can see that how it changes here. So determine the number of inches or centimeters that the two mispositioned structures are off in the projection. So estimate how much the structure situated furthest from the IR will move per 5 degrees of angle adjustment placed on the CR. So When you're looking at a knee, so here we have the medial condyle. We know this because there's the abductor tubercle here. So here's your lateral condyle. So when we look, we need to move. We are off. We need to adjust this. How are we going to fix this? You take a look and see if the body is lying here in A, supine, so this is a 0 angle. This is a 90-degree angle, so the central ray will come in this way. This is 0. This is a 45. So in between the 45, there's a 23-degree angle. Between the 45 and 90, it's a 68-degree angle. So if the patient is laying on their side, coming through is 90, coming across is 0, you have your 45, and in between there's a 23 and a 68, okay? Looking here on a knee, coming down the femur, straight down is 0 angle. Coming straight up, straight across, perpendicular to it is 90 degrees. Coming down at an angle is 45. So if you need to adjust it, you're going to go, there's 23 in the middle and there's 68. You can divide 23 in half and you'll be here. Okay, so that's kind of how we're looking at the knee or any anatomical parts, not just the knee. You can look at the body and you can decide, okay, I'm rotated how much, and how much do I need to correct? So this is giving you some kind of foundation when you're going back to repeat an image. So when looking at this knee, you can see here that we are rotated. So you're going to determine, okay, how far off are these two? So let's just pick a number. Let's just say it's about 1 inch off. What you're going to do is you're going to want to rotate the knee half an inch because both parts move. So the medial and the lateral condyle are going to move. So you're going to go half the distance in rotating the knee in the correct way, or the body part in a way that is half the distance because both parts moved. If only one part moved, you're going to go the full inch instead of just the half inch, okay? So you're going to take it and divide it in half because both parts move. If only one part moves, then you're going to move it the full distance. That's how that works. Okay, so we're going to talk about the sharpness of recorded detail, and you guys should be pretty familiar with this. This should come pretty naturally for you. So the factors that affect the quality of detail sharpness include your focal spot size, your distance, so your SID, any kind of motion, the double exposure, that's a bummer. It happens. The spatial resolution of the IR also. So if we're talking about CR versus DR and the DELs and your pixels and everything else. So if we look here at the sharpness of recorded detail with your focal spot size on A, this is a small focal spot, whereas B has a larger focal spot. If you look closely, you can see your bony trabecular markings better on A. So you get better detail with doing that. When we look at the pixel size, so if you take a 14 by 17 with your pixel sizes, you can see that they're very large. These have the same pixels, same amount of pixels, but with a 14 by 17, they're a lot bigger than they are with an 8 by 10. So grabbing the correct cassette size, grabbing the smallest cassette size that you can, or image receptor, is going to give you a higher resolution. So you want that. So looking at the spatial resolution between using a small and a large image receptor, so A is an 8 by 10, whereas B is a 14 by 17. You can see the detail within the 8 by 10 so much better than you can on a 14 by 17. So this is visually the difference that the radiologist needs to see. So you can see this line here is a lot clearer here. Okay, so when we talk about radiation protection, we're talking about repeats here and ways to reduce the radiation exposure through repeats, through collimation, through immobilization, through communication, through your skin doses, and how to reduce dose for a pregnant patient, and the proper way to shield. So when looking at this image here, so you can see that the shielding was here. So here is your field right here. And then they placed a shield across here. So this is your lateral L5S1. And you can see that the shielding was very good. Looking here for an AP, you can do this to help reduce, or I'm not sure, this is a lateral, so this is just showing you the reduction of dose in protection, so in turning your box there. So in here, if you shoot it straight, you can see that there's lead that was put over the, hopefully, gonads of the male-female patient. Now, shielding on a female patient is really hard, and I'm not going to tell you to do it. I'm going to tell you to try, and if you feel comfortable, go for it. There is this misshapen little shield that you can slide just on the inside of the pelvis. Now, if you have a large patient and this has a magnification that's going to get into your bony anatomy because of the divergent beam, you're not going to want to use it. So you can use it on thin patients when you really feel comfortable placing it. For male patients, I do expect to see some kind of shielding. So this is a great one for the pelvis. You can see it slides up right over the gonads there on the patient. So here's shielding of radiosensitive cells not within the primary beam. We can do that. It's usually within 2 inches of the primary beam is where we want to shield. The best thing you can do is collimate as much as possible, and you want to use your exposure factors to minimize the patient exposure. How do we do that? Increase your KVP, lower your mass. A lot of the scatter happens within the patient, so if you're within 2 inches of the shield should be on there, but most of the scatter happens within the patient, but it definitely makes patients feel better if we shield them. And then make sure you set your automatic exposure control to 150% of what you would use. Here, oh my gosh, so a lot of things wrong with this left hand here, lateral hand. So someone's taking their hand and trying to open up the other hand. So there should be a lead glove on that hand. There's no marker, there's no collimation. Very important that this doesn't happen. I hope I never see this. You can use sponges, sandbags, whatever is needed to help get that hand open, okay, without using someone else's hand. So that is the bulk of your image analysis chapter 1. I kind of skimmed it. It's a good read actually, and it talks about a lot of stuff that's really important within the chapter on how to keep dose creep down, keep your collimation. Chapter 2 talks about, I'm not going to go through chapter 2 with you because I just taught the digital imaging class to you. So there's the digital imaging guidelines. I really like the chapter though. It does talk about your lookup tables and your histograms and everything that's really important that you know. So I do require you to do the workbook. You're going to have to do workbook 1 and 2. But I put chapter 2 PowerPoint up for you, but I'm not going to go through it because of we just went through that class. So it should be a good review for you. Okay? Take the quiz. Other than that, you're all set.